Continuing on with chapter 35. So, heart failure kind of is going to differ depending on which side it is. And heart failure is just the heart's inability to pump enough blood to force the blood forward within the circulatory system. And so it starts backing up. And so left-sided is definitely more common, but can definitely either progress to right, or you can have just right-sided heart failure by itself. So with right-sided heart failure, the fluid is going to back up into the body, and it's typically going to settle at the lowest gravitational point. So you'll end up seeing swelling in the feet and the ankles, as well as in that sacral area right just above the butt. If they're in a seated position, fluid can back up there as well. And when you actually press on it, how deep of a pit your finger makes, the worse it is. Left-sided heart failure, your fluid is going to back up into the lungs itself, which you're going to end up causing pulmonary edema, shortness of breath. When you're listening, oftentimes you're going to hear crackles or that fluid, kind of that bubbly sound. Oftentimes you'll have a chronic cough, and you may end up coughing up white or pinkish tinted sputum, and that's because you're backing all that fluid up into the lungs. It's pulling out different secretions that are supposed to be in your lungs, and you end up coughing them out. Paroxysmal nocturnal dyspnea is having a hard time breathing that continues to wake a person up at night. And so typically what they start doing is sleeping elevated. They'll start in bed with an extra pillow and then continue to increase pillows. And then eventually they're going to get to the point where they can't even lay in a bed. And so they end up sleeping on a couch or in a recliner so that they're in a more upright position. You could definitely know how bad their dyspnea is by how many pillows it is that they use. And that's definitely something that you can document to give other people an idea of how bad they really are. Stroke is the leading cause of death in older people, just in general. A lot of it is preventable. So lifestyle changes, smoking, obesity, living a sedentary lifestyle, lack of exercise, those sort of things can definitely reduce people's risks, but there are uncontrollable factors, age, race, and gender. They just can't really do anything about. Signs and symptoms kind of depend on where the stroke has occurred, but kind of the classic signs are hemiparesis or muscle weakness on one side of the body, facial asymmetry. If you have them smile, the side that is affected, they won't be able to actually smile on that side. They'll have facial droop. Headache is common. Changes in blood pressure, common. Confusion, slurred speech, the inability to understand speech, or problems getting the words out. There's two types of strokes. There's a hemorrhagic stroke and there's ischemic stroke. So hemorrhagic stroke is actually bleeding. They're hemorrhaging somewhere. So a broken blood vessel is causing bleeding into the brain. They are less likely, but they're more likely to be fatal. Ischemic strokes occur when a blood clot is blocking flow of blood to a portion of the brain. What we want to try to determine is when the person was last seen normal, because that can affect their treatment significantly. If the symptoms have occurred recently, the patient will be a candidate for some medications within the hospital. If it's been too long, they're not a candidate for those medications, so it's definitely important. If it's an unknown amount of time, they'll err on the side of caution most of the time and not treat them with the medication. Transient ischemic attack, also known as a TIA, basically presents the same way as a stroke, but it resolves itself within 24 hours without treatment. So it's not a true stroke. They used to call these mini strokes, but that's not the case anymore. So it's transient because it goes away. Other changes within the nervous system, you have a change in thinking speed, memory, postural stability, but that doesn't necessarily mean that they lose IQ. What has been found is that while there's a lot of things that decline with the aging process, overall IQ is not one of them. It's more the ability to respond to questions that has been decreased. And so you have a person whose body is declining overall, but they're still there mentally, and that's what leads to a lot of geriatric depression. The brain decreases in terms of weight about 10 to 20% as the patient ages. So you end up increasing the amount of area between the brain and the skull, which makes your brain easier to move around in there. So you end up with a more likelihood of head injuries. There's about a 5 to 50% loss of neurons. So you end up having problems controlling the rate and depth of breathing, heart rate, blood pressure, hunger, thirst, regulation of body temperature. And this leads to a decline in performance of the majority of the sensory organs. Changes in vision, vision acuity, depth perception, the ability of the eyes to accommodate for light or constrict or dilate to let the correct amount of light in definitely decreases, as well as the ability to differentiate colors that decreases over time. Cataracts is a clouding of the lens, which can increase the likelihood of falls and medication errors. Decreased tear production leads to drier eyes, the inability to see close up, also known as presbyopia. There's a number of diseases that also end up decreasing the visual acuity in older adults, so glaucoma, macular degeneration, and then retinal detachment. Hearing issues, the hearing in the inner ear make it hard to hear high frequency sounds. There's a video on YouTube that I would suggest looking up. It's called the mosquito ringtone. That may or may not be something that you guys have played with. It was big when I was in high school because all of us as students could hear it because it was super high pitched, but the teachers couldn't hear it. But it's kind of an interesting experiment, especially if you're sitting there with like your family and there's a bunch of varying ages to see how that changes. Oftentimes you guys will be able to hear this, but anybody above the age of 30 struggles. So definitely check that out. Other changes, you get changes within the ear with balance and proprioception, or how your body can determine where your limbs are in space without actually being able to see them. And that causes problems with balance, makes it more likely to fall. Presbycusis is a gradual hearing loss that occurs with just normal aging, but that doesn't mean that they're super hard of hearing. That's why we start out at a normal volume and change depending on how our patient can hear or not hear. Heredity, long-term exposure to loud noises is definitely the main contributor to hearing loss. And we're much smarter nowadays about wearing hearing protection. But then we also put in earbuds and crank the music up. So taste, the sense of taste can be diminished just because there's a decrease in the number of taste buds. And so oftentimes what the patients will say is nothing tastes good anymore. And so you kind of lose that interest in eating. Like if all of your favorite things didn't taste normal anymore and it was just kind of bland, you'd be like, meh. You wouldn't really care about eating anymore either. Touch. Any geriatric person may have a decreased sense of touch and or pain perception because you end up actually losing nerve fibers. And so it takes a lot more stimulation in order for you to perceive some signals that you used to perceive really easily. Older persons may be injured and not actually know it because of this loss of nervous tissue. And then also there's a decreased sensation of hot and cold, and they don't thermoregulate well either. So your patient is more susceptible for hyper or hypothermic incidences because they just can't sense the difference. Dementia is a slow onset of progressive disorientation, shortened attention span, and loss of cognitive function. Not everybody has dementia. They may be confused. That doesn't necessarily mean that they have dementia. You need to find out what is normal for the patient themselves so you can truly know. Dementia is not just confusion, it's a irreversible condition most of the time that causes a progressive loss of cognitive abilities, psychomotor skills, and social skills. Potential causes there are thought to be a genetic predisposition here, but long-term high blood pressure, smoking, etc., can also lead to dementia. Patients may end up having short-term, long-term memory problems, decreased attention span. They can't perform their daily routine for themselves and end up having to need help with that. They show a decreased ability to communicate, often appear confused or angry. They have impaired judgment. They may be unable to vocalize areas of pain or other symptoms that they're experiencing, and they also may have a problem following commands. Delirium is a sudden change in mental status. So whereas dementia is a long-term chronic, delirium is very quick onset. It's marked by the inability to focus, think logically, and maintain attention. Delirium affects 15 to 50% of hospitalized people that are 70 years old or older. Usually the result of some sort of reversible physical ailment, a tumor or a fever, metabolic causes, often just taking a elderly patient out of their normal environment kind of sends them into a tailspin. Assess and manage the patient appropriately, oftentimes just using interviewing type techniques, remaining calm, kind of trying to talk the patient down is going to be mostly what we're going to do for them out in the field. For syncope, this is also known as fainting. We're always going to just assume that there's something significantly wrong with the patient until we find otherwise. Is it unusual for a person within the geriatric group to end up fainting or near fainting? No, it's not, but we don't want to end up missing something, so we just want to make sure that we cover all of our bases. Syncope is often caused by an interruption of blood flow to the brain, and it may be just transient, or it may be something much more life-threatening than that. Neuropathy is a disorder of the peripheral nerves in order to function. It can be a part of either peripheral motor, sensory, or the autonomic nerves. Symptoms depend on what the nerves are affected. So it might be motory, it might be sensory, it might be autonomic, it might be a combination of, but you just don't get the same signals and sensations that you're supposed to be getting. We'll go ahead and stop here and we'll continue on in the next one.